So it's a real privilege to be in front of you to acknowledge this part of the session, which is to announce to you this year's CRT, AKI CRT from San Diego award for a physician scientist clinician who brings the discoveries from science back into the bedside. So just to give you a brief idea of what this award is, so it was established in 2016 to honor a San Diego scientist, Dr. Jeff Gray, who made seminal contributions in development of kidney biomarkers, which are now in routine clinical use. And in all this, it acknowledges the contributions of scientists like him who bring forth a lot of painstaking work to make it applicable for clinical care. Since 2016, we've had the privilege to award this to multiple people whom you will all recognize. And today, it's my distinct honor to invite Dr. Ashita Tolwani, this year's recipient for this award. Ashita, please come on up. Thank you. And Ashita has made some seminal contributions in this field for many, many years. She is well recognized for all her work, and it is my distinct privilege, Ashita, you're right, keep hiding behind me. To give this to you. Ashita, welcome. We got a picture here.
First of all, I'd like to thank Dr. Ravi Mehta and the organizers of this conference for allowing me to speak every year for the past 10, 15 years. It's been an honor to be part of this conference. I want to thank Ravi and also the award committee for giving me this award, which was totally unexpected. And when I received the email, I was definitely overwhelmed. I never imagined that I would be standing here in front of you after going to this conference for years and be the recipient of such an award. And with that, I would like to go into my talk, which will hopefully honor the legacy of Dr. Gray. And I'm sorry it's not the same title as you see in the brochure, but I thought it'd be best to focus on how simple ideas or solutions to clinical problems and the dissemination of education can make an impact. So this is a journey of simplicity and impact in CRT. So I want to focus first on the legacy of Dr. Jeff Gray. Unfortunately, I was not able to meet this exceptional person, but as Dr. Mehta already said, he was committed to addressing scientific challenges that directly impact patient care, leading to practical solutions anchored in sound scientific principles. His legacy, as already mentioned, is pioneering research on biomarkers, which we now use often in clinical practice. My sincere hope is that my talk today honors the spirit of Dr. Gray's innovative and impactful work and inspires everyone in this room to enhance patient care through scientific exploration. So with that, I would like to go through my journey. I would like to talk about the status of CRT when I entered the field, my early mentors and influences who continue to influence me today, the development of a citrate protocol at UAB, the recognition for the need for CRT education, CRT Day to CRT Academy, future directions, and my conclusion. So let's start at the beginning of CRT at UAB. I just finished at that time doing a critical care nephrology fellowship at the University of Alabama at Birmingham. And at that time, we had already started increasing the beds in our ICU and realizing the need for renal replacement therapy in the ICU. We had 2 Prisma machines, and many of you may have recognized the Prisma machine on this picture. And the challenge I was given is to address the growing need for renal replacement therapy in the ICU, specifically CRT, and not only that, but enhance the safety and effectiveness of anticoagulation in CRT, because at that time we only provided no anticoagulation or heparin, and this limited the use of anticoagulation or the delivery of this therapy to our patient population. So therefore, let me talk about my influences. I had to come to learn. And these are the guiding stars in my journey and why I'm here today. These people do not need any introductions. Of course, you have Professor Ravi Mehta and Professor Claudia Ronco, whose conferences and whose mentorship and advice over the years are the reason why I'm standing here today. And I remember being awestruck at my first conference in San Diego at Coronado. And at that time, Dr. Mehta was pioneering his citrate protocol, which has become revolutionary, of course we know, and citrate's accepted in CRT. And I was thinking, how can we bring such a protocol to UAB? So I took all the tools and knowledge I gained from him during my conference and took it back to UAB. And unfortunately, we couldn't input or implement his exact protocol, but I took the concepts he taught me, and we came up with this citrate protocol, which is using trisodium citrate 2%. Now, at this time, we did not have commercially available dialysate solutions. So what we used was normal saline with potassium and magnesium, and we implemented this therapy in 1999. We published our results in 2001. And what we recognized at that time was that these solutions had limitations, both trisodium citrate and also ACDA, because they're not approved by the FDA for the intended use. And we did observe significant adverse metabolic effects, including hypernatremia and metabolic alkalosis. And often with these solutions at that time, without having commercially available solutions, that required customization of solutions with hyponatremic concentrations. Well, with this protocol, what happened is that the 2% trisodium citrate, which usually is hung on the pre-blood pump at 250 cc's an hour, accidentally got hung as a dialysate at 1,000 cc's per hour, which was our protocol. And this was in our best intensive care unit with a seasoned nurse. And I remember very well this patient in the ICU. She was 22 years old. Her ionized calcium dropped dramatically. And with that, she became hypotensive, developed arrhythmias. Luckily, we recognized it. We were able to give calcium, and essentially, she was fine. But this made me think that there's more to this than just implementing a protocol. There's a huge education process. How can we simplify this? How can we fix this problem so where I can sleep at night, not worry about metabolic abnormalities or complications from anticoagulation, but still able to deliver this therapy to our patients? So we thought, what can we do? And it just became apparent that our solution was to create a physiological isotonic solution that was diluted from the concepts that I already learned from coming to this conference, and to make it where the rates delivered were very similar to the rates you would deliver with dialysis or the dialysate or replacement fluid. And therefore, if mistakes happen where the solutions may have been hung on the wrong scales, then we wouldn't have such metabolic catastrophes. And this was what we came up with, and we published this in 2006. And since then, this essentially has been our protocol with maybe changes in the device and some of the commercially available solutions. So after doing this publication or implementing this protocol, what did that do to me at UAB? Well, 1999, 2 Prisma machines. After coming here and learning all about citrate from Dr. Mehta, we implemented our citrate protocol, and you can see how our number of machines increased because we could deliver CRT to more patients than we could before, and it worked. And the intensivists were recognizing this. Then comes 2004, where we implemented our newer citrate protocol, hopefully to improve safety, and the rest is history. So you can see over the years what has happened with our number of CRT devices. And just to summarize, up to 2022, where I stopped collecting this information for this presentation, we have 42 devices. We do 800 and 1,000 patients a year. It is a big program. And the only reason we've been able to do that was secondary to the tools and what I've learned here from all of the experts that have been at these wonderful conferences. So with that, our CRT patient days increased. And with this publication, I started getting calls from all over, everywhere, that they wanted to implement a similar protocol, whether it was from the United States or outside. And this is the one that made me smile. This was a group from Australia. I can never even imagine. I've never been to Australia. And this was a group from Australia who I'd been helping back and forth by email and calls to implement their protocol, or using a similar protocol to what we have with their devices that they used. And this made me smile because in their title, they put the Modified Alabama Protocol. And it's so nice to hear Alabama having a positive effect in the media for once. Trust me, you know what I mean. So I have always saved this paper just to say we can do good in Alabama. So with that, though, it became very apparent that there was a huge gap in the education in CRT. All these practicing physicians, trainees from everywhere, it was clear when they emailed me that the understanding wasn't there, even at our own institution, not just among the nephrologists and trainees, but nursing, from other providers, etc. So then that incited my passion for education. How can I educate these people and bring all these teaching tools in place that are innovative and will focus on how different learners learn? And so I developed what's called a Fundamentals Didactic Slide Deck, a UAB CRT primer, problem-based homework. Yes, I am known at my institution for giving homework. My fellows go home and say, I can't go out. Dr. Tolwani has given me homework that's due tomorrow. We also have had hands-on practicals, pre and post exams, and simulation. We keep growing and changing to meet everybody's needs. So just to give you an example, I know you can't see this, but one of the things that we've developed at UAB is called a CRT primer, which is meant to be the how to do your own CRT when nobody's there for new fellows who start. And over the years, this is a practical guide that's now nearly 30 pages. And what it has is the basics of CRT, the fundamentals, how CRT differs from intermittent hemodialysis. These are just basically some excerpts from the whole primer. It talks about our machine. My mantra is you have to know your machine. Be an expert in your field. If you haven't touched your machine, Dr. Serta can verify, then you don't know what you're doing. So it has the specifications of our devices. It has our protocols. It talks about citrate. It talks about the complications. It's all specific to what we do at UAB. It basically even has a sheet that says, essentially, if the ICU nurse calls you for various abnormal ionized calciums, how to troubleshoot. It also has formulas for dysnatremias, formulas for dose, formulas for how to determine drug clearance and CRT. So it's a very, very practical guide that I update every year that the fellows get, and I disseminate to anyone who wants it. In addition to that, I give homework. This is an example of homework. I make fellows calculate things. How many of you went to the pre-course? You know we love calculations. What I love about CRT, the math is pretty simple. So I made fellows calculate dose, filtration fraction, whatever modality a patient was on, to be able to do those things. And I also had practicals where the fellows and faculty had to come and show me they knew their machine. Tell me which scale represents what. Show me how the screens work. Be able to alter the prescription. Be able to implement the weight and hematocrit. How many of you can do that on your CRT device right now? How many don't know what I'm talking about? So touching the machine, and they had to show to me they could change the prescription. These were all hands-on, where I watched them and did a check-off, not only for fellows, but faculty, trainees from everywhere. So this was my hands-on practical, and now that led to exams. At the time that I implemented all this, I happened to be the program director for our fellowship. So the first ever American Society of Nephrology in service, many of the CRT questions were developed from us, which is exciting. And those of you know me know I have banks and banks of multiple choice questions. People email me from all over saying, hey, we want to have some questions. Can you give them to me? And I said, yes, but I won't give you the answers. You have to email me back. Then I can see if you do the answers. So this is all making me realize, or maybe realized, how important education is. And as we implemented this citrate protocol, grew our program, and did institutional education, outside word, or people from outside were emailing me, said, hey, We really want you to do something at UAB where we can learn about CRT on a practical basis and share your educational tools with us if you don't mind. So that led to UAB CRT Day back in 2004, which was simply a day where local practitioners all over Alabama came to learn about hands-on how to implement CRT and how to simplify the process. And over the years, more and more people asked me to expand this to other places. So that was the birth of CRT Academy in 2007, which now we've been having every single year, and it's based so much on what we have done here, what Dr. Mehta has done here. The objectives are to teach CRT fundamentals for immediate practical skill use. It's focused on practical skills. It gives practitioners competence to manage programs and become local experts. It's very hands-on. It's now expanded to a 2.5-day conference and even has a POCUS workshop. And it's attended by nephrologists, critical care, nurses from everywhere, and we even have international people attend. So the conference includes lectures, hands-on workshops, simulations, and interactive problem-solving sessions. And to me, what's really excited me is some of the fellowship programs in the United States have made it their mandatory training for CRT, and they send their fellows every year, which is very, very exciting for me to see. So that's how CRT Academy forms, and I just want to show you some pictures because you will recognize some of these people in the audience who were the wonderful speakers at the pre-course for those you attended. So we have fun. I think some of you in the audience may recognize who you are here. We also have very close interactions. You can see it's small groups, it's one-on-one and personal with our experts to really focus on how to do the prescription. There's no ego here. We're all on the same level. We all learn from each other. We're all very approachable. And we still know how to have fun. So just to let you know, we can have fun in Alabama. And with that, the impact and recognition over the years has now led us to ways to disseminate this information so other people can do it everywhere. I was fortunate to have Dr. Javier Nera come as my co-director, and he's at University of Alabama now. And with that, he determined that we should now start writing about what we do. So this was in 2022, on our anniversary, this was our first proceedings of that CRT Academy. And all those authors on that publication are my speakers, are my experts, are the ones who help me with CRT Academy every day. And I want to give a special shout out to Dr. Pedro Teixeira, who took the initiative and did the most of the writing. This is so exciting, and I must say now we even have American Society of Nephrology endorsement, so we can definitely bring this to more people in a very digestible way and make learning fun. So where are we with future directions? You've heard about this throughout this entire conference, but from my perspective, from a practical and an educational standpoint, which I'm standing here for, this is what I think. Yes, precision medicine is here. We will see more of tailoring CRT treatments to the individual needs based on genetic, biomarkers, and phenotypical characteristics and artificial intelligence. We need more technological advances. The machines need to be made more safer, advanced, with filters that are safe, biocompatible, efficient, and provide more precise clearance, and with less needs for complicated anticoagulation. Safety is a big issue, so we can provide this for patients and make it safer for patients. Simplified protocols. I'm a simple person, that's what I believe in. Creating more simple, standardized protocols that can be easily implemented, less places like in rural Alabama. I know that there's a participant here from Selma, Alabama, I think he left, who is trying to implement a CRT program there. And so this would be very helpful to have protocols that are been verified, simple, and he can institute at these places that may not have the support like a large academic institution. We're going to see integration with other therapies. We're going to see simpler, hopefully, simplicity of combining CRT with other treatments like plasmapheresis, hemoperfusion, absorption. Telemedicine. I don't know about you, but at my ICUs at UAB, we're always on diversion. And so these rural places that don't have the specialization to do these technical aspects of dialysis in the ICU often try to transfer patients to us, but we're always full. So now with telemedicine, remote monitoring, we've been trying to utilize that to manage renal replacement therapy, to improve patient outcomes and facilitate expert support at these other institutions, which will help patients and basically save lives since they don't have to travel from far away all the way to UAB, which often does not have any beds. And with this, it's so important to continue this education process and dissemination of information, especially the new advancements, especially going to conferences like this, like other conferences to be able to do this. And we already heard with the lectures before about the research and clinical trials that need to be done. So my concluding thoughts. I hope what I can convey to you out of this lecture is that often significant medical breakthroughs don't always come from complex research. Sometimes they're a product of just problem solving, practical problem solving. So please, all of you out there, especially the newer generation, trust your insights and never overlook an idea's potential. The simplest solutions can have the farthest reach. This is what I've learned. Also, perseverance and consistent practice are essential. That's what turns ideas into solutions that can be adopted globally. And expertise in an area is just not about acquiring knowledge, but it's about sharing that knowledge. It's sharing in a creative and educational way so others can use your knowledge and expertise to take care of patients. Effective dissemination of expertise can further the field. It really can. I'm an example of why I'm standing here, and I never thought I would be, and catalyze the recent next wave of advancements. And finally, I cannot emphasize more the role of mentors is invaluable. Having role models to look up to you can guide and inspire your journey, just like my role models here and at the other conferences I've been to. This is a foundation upon which to build your innovation. So who are my role models? You've seen them, but I also want to give a special shout out to Dr. Serta over there, he's smiling at me, because he has been a mentor for years, providing me with good advice, and I've learned so much from him. Of course, I'm always in awe of Dr. Mehta and Dr. Ronco. Sometimes I can't even speak in front of Dr. Ronco, and I wonder if he thinks I'm a complete idiot because I'm so awestruck at times. And that's the honest truth. So I just want to end with these two quotes. Great things are done by a series of small things brought together, and innovation is seeing what everybody has seen and thinking of what nobody has thought. So keep that in mind. You all can do it. And finally, happy World Kidney Day. And for the nerds out there like me, happy Pi Day, 3.14, March 14th. Thank you very much. And thank you again for everybody for this great honor.
Congratulations. Thank you so much. Now, please.